Okay, welcome everyone. Today we'll be looking at medications you need to know for the NCLEX, and we'll be starting with antihypertensives. There are some major classes of antihypertensives you need to know for the NCLEX. One of them would be your ACE inhibitors. And one way to remember your ACE inhibitors is that majority of them end with the suffix prils. So your Enalapril, your Benazepril, Captopril, those are our ACE inhibitors. What are major side effects of ACE inhibitors? One of them would be that they can affect fetal renal function and lung development. So they are kind of teratogenic. They can cause fetal death. And as such, this is contraindicated in pregnancy. Other side effects you would see in clients who are using ACE inhibitors would be this symptomatic hypotension. They will have this intractable cough. You would also see hyperkalemia in these patients. So again, remember, if you do an ECG on these patients, you would see tall peaked T waves. So that will tell you your client possibly has high potassium level. You would also see angioedema, which would be that swelling of the face and the airway. There would also be temporary increase in serum creatinine. You also want to remember that orthostatic hypotension is a common side effect of antihypertensives, even antipsychotics, antidepressants, diuretics, narcotics, and even vasodilator medications. So again, we said your ACE inhibitors end with pril, your Enalapril, Benazepril, and Captopril. We said they could affect fetal lung function and renal function. So we don't want to give them to our patient who is pregnant. And the major side effects you would also see would be this intractable cough and hyperkalemia. We said you would always see angioedema and orthostatic hypertension. So again, take note of the items that are placed in red. We also have our Angiotensin II receptor blockers, or your ARBs. You also want to remember your ARBs because most of them end in sartan, your valsartan and your losartan. So these are your Angiotensin II receptor blockers. You would want to remember that if clients are unable to tolerate ACE inhibitors, we can actually give them our ARBs, such as your valsartan or losartan, if they are not able to tolerate your ACE inhibitors. Just like with our ACE inhibitors, our sartans or our ARBs can also cause fetal injury or death, and we said it's contraindicated in pregnancy. It can also potentiate hyperkalemia in your patients. So you want to remember that with your ARBs, your valsartan and losartan. We said we want to remember that they end in sartan, and they are teratogenic, and they could also cause hyperkalemia. Another class of antihypertensive would be our beta blockers, and you would notice that they end in olol, olols. So these are our olols, your metoprolol, your timolol, your atenolol. So these are our beta blockers, and they end in olol. The major adverse effects you would see with your beta blockers would be they could cause bradycardia, they could cause bronchoconstriction. So you want to remember that with the NCLEX, because this is an airway risk. So your beta blockers, like your metoprolol, they could cause bronchoconstriction. They could also decrease the heart rate in your patients, and they could also decrease libido. And you could also see erectile dysfunction as a result of that decreased libido. So again, if your client is on beta blockers, maybe they are complaining of wheezing, or you notice that they are wheezing, You want to start thinking, could that be an adverse effect of that beta blocker? Because we said they could cause bronchoconstriction in your client. So you want to look out for wheezing that could tell you your client is suffering from an adverse effect of that beta blocker. So again, your angiotensin II, your valsartan, your losartan, your sartans, we said they are teratogenic and they can potentiate hyperkalemia. And with your beta blockers, which are your olols, your metoprolol, your timolol, your atenolol, we said they end in olol. They can cause decreased heart rate, bronchoconstriction, and also decreased libido. So this will be decreased libido. Another class of antihypertensive will be your calcium channel blockers. Again, you will notice they end in pine, nifedipine, amlodipine, felodipine, nicardipine. So those are your calcium channel blockers. Again, with the pins, one major issue you should be concerned about would be that safety risk, because it can cause dizziness. That's one of the adverse effects. Your calcium channel blockers can cause dizziness in your client, so you want to be conscious of that safety risk. Again, it could also cause flushing, headaches, peripheral edema. It could also cause constipation in your clients. Remember, these calcium channel blockers are vasodilators that can be used to treat hypertension and even chronic stable angina. We also have our non-dihydropyridine calcium channel blockers. For example, your diltiazem and your verapamil. These are examples of your non-dihydropyridine calcium channel blockers. And again, they could decrease the heart rate in your patient. So you want to avoid giving your patients diltiazem or verapamil, especially if they're already bradycardic. Let's look at a sample question where we can see our antihypertensive. So a client with chronic heart failure developed an intractable cough and an incident of angioedema after starting Enalapril. Which prescription does a nurse anticipate for this client? Again, you want to remember we talked about our ACE inhibitors, and we said major side effects of your ACE inhibitors, your angiotensin converting enzyme, would include that symptomatic hypotension. You would also see that intractable cough. You would also see hyperkalemia, angioedema, which would be the swelling of the, or edema of the face and the airway. Again, we could see that temporary increase in serum creatinine. So remember, we said that for clients that are unable to tolerate ACE inhibitors, we can give them ARBs, our angiotensin II receptor blockers. What are examples of your ARBs? Our valsartan and our losartan. So we can give them that in place of our ACE inhibitors if they're unable to tolerate our ACE inhibitors. So again, we'll just rush through them. Alprazolam would be an anxiolytic. We don't use this to treat heart failure. Your dextromethorphan is actually a cough suppressant. Again, a cough that is caused by an ACE inhibitor will not be improved by giving a cough suppressant, because it's the ACE inhibitor that is causing the cough. So this would not help this patient. Option 3 says lisinopril. Lisinopril is an ACE inhibitor. We're already saying that the client, remember, this is your pril. This is another pril. Again, since the client is not tolerating enalapril, which is an ACE inhibitor, he obviously will not tolerate the lisinopril. So again, our best bet, our best answer would be to give valsartan. Remember, we said valsartan, your sartans, valsartan, losartan, they are your ARBs. And if your client is unable to tolerate your ACE inhibitors, then we can give them our ARBs or our sartans. A male client with hypertension was prescribed amlodipine. Which of these adverse effects is most important to teach the client to watch for? Okay, so again, he has been prescribed amlodipine. So those are our pins, and we said these are calcium channel blockers. We use them to treat hypertension. We use them to treat chronic stable angina. And we said one common sign or one common adverse effect of this medication would include dizziness. So again, I'm already looking out for dizziness as one side effect. We also said you would see flushing, headaches, peripheral edema, and even constipation. So again, with option 1, this would be a side effect of, or an adverse effect of a beta blocker. Remember we said beta blockers, part of the side adverse effects would include bradycardia. We said you could see bronchospasm. We said you could also see erectile dysfunction because they decrease the libido. So this would be a side effect of a beta blocker. With option 3, the dry cough. So that would be more of a side effect of our angiotensin converting enzyme, your ACE inhibitors. So we said you will see that intractable, non-productive cough. So this would be a side effect of your ACE inhibitors. And then with option 4, so I'm just trying to rule out all of these options. So again, we said with calcium channel blockers, we said we'll see dizziness. We also said you will see those peripheral edema. So again, this would be as a result of a calcium channel blocker adverse effect. So number 2 would be our correct answer. The nurse is assessing a client with hypertension and essential tremor 2 hours after receiving a first dose of propranolol. Again, you can see our olol. Which assessment is most concerning to the nurse? Okay, the headache normally could happen, or we could see headaches with clients with hypertension. So that would be a common occurrence with hypertension. The current blood pressure of 160/88, would that be most concerning to the nurse? Again, remember, this is the first dose of this medication. So it may take a while. It may take some days of treatment for the blood pressure to reduce to a normal, a more normal value. So I won't be concerned about this reading. How about option 3? The heart rate has dropped from 70 to 60. Again, this would be expected with our propranolol. If we see that reduction in the heart rate, that would be expected. We'll just need to continue to monitor it for further reduction. And again, with option 4, we see an airway problem here. We are seeing slight wheezes or auscultated during inspiration. That would be an airway problem. So that wheezing in a client that is taking a beta blocker like propranolol, that may indicate bronchoconstriction or even that bronchospasm we talked about. So option 4 would be our correct answer. So let's look at one more question. Well, maybe before we look at another class of medication. The nurse is preparing medications for a group of clients. Which prescription should the nurse clarify with the healthcare provider before administering? Okay, client diagnosed with cirrhosis, had 2 stools today. Lactulose was prescribed. Remember, lactulose is given to patients with cirrhosis and hepatic encephalopathy. That's going to help to promote excretion of ammonia through their feces, through fecal elimination. So again, this would, we don't need to clarify this. This looks fine. How about option 2? Client prescribed lisinopril per oral daily, and the serum potassium level is 5.6. Okay, remember we talked about our prils. So what does your pril remind you? An ACE inhibitor. And we said one adverse effect that these ACE inhibitors can cause would be hyperkalemia, especially in the presence of renal insufficiency. So we'll need to clarify with the healthcare provider before we administer this medication. You can see the potassium level is elevated. Normally, your potassium level should be between 3.5 to 5. So we already have the potassium level elevated here. So you will need to clarify this with the healthcare provider. But again, let's look at other option. Option 3 says, client is receiving vancomycin and we are seeing mild facial flushing after 30 minutes. Again, would this be concerning to your clients? Again, it depends on how the vancomycin is being given. It should be infused over at least 60 minutes. And if it's infused too fast, the client may develop what we call red man syndrome. That's where you see this facial flushing, upper body flushing. So if you see this, you just need to either slow the infusion or stop it and restart it at a slower rate after 30 minutes. So this facial flushing is not indicative of an allergic or anaphylactic reaction, and the nurse can independently manage these side effects. So that would not be concerning. And option 4, client with diabetes, insulin glargine, current blood glucose is 100 milligram per DL. Remember, glargine is also called Lantus. Lantus is a long-acting insulin. It doesn't have any peak period, and it should be administered even if the current blood glucose is within normal limits. So this will not be concerning. So option 2 would be our correct answer. Remember, we said these ACE inhibitors can potentiate hyperkalemia. So that would be our correct answer. I hope this is the last one. Okay, so this is the last one before we look at another class of medication. The nurse prepares to administer morning medication to assigned clients. Which prescription should the nurse clarify with the healthcare provider? Okay, so here we have clopidogrel, which is an antiplatelet medication that's given to a client with a history of stroke. And we see a platelet count of 154,000. Again, your normal platelet count should be between 150,000 to 400,000. So this is still within range. This antiplatelet is working as it should, so we shouldn't be concerned about it. We don't need to clarify this. How about number 2? Losartan, which is your losartan, sartan, for a client with hypertension who is 8 weeks pregnant. Remember, we said your Angiotensin II receptor blockers and our ACE inhibitors, they are teratogenic. We said it can cause fetal injury or death, and is contraindicated in pregnancy. So we'll need to clarify this with the healthcare provider. But let's look at option 3 and option 4. Prednisone. So that would be a corticosteroid, if I'm not mistaken. So prednisone, given to clients with herpes simplex lesions and Bell palsy. So with Bell palsy, what do you see? We see this acute onset of one-sided facial paralysis, and it's usually related to the inflammation of the facial nerve, your 7th cranial nerve. And what could trigger it? Herpes simplex. A viral illness like herpes simplex can trigger Bell's palsy. Again, part of the standard treatment would be to give corticosteroids like our prednisone within 72 hours of symptom onset. So we would not need to clarify this. How about tiotropium for clients with pneumonia and COPD? Again, tiotropium is an inhaled anticholinergic drug, and it inhibits receptors in the smooth muscles of the face. It's prescribed daily for the long-term management of bronchospasm in clients with COPD. So again, we won't need to clarify this with the healthcare provider. So option 2 would be our best bets. Now let's look at antidepressants, and we'll start with our monoamine oxidase inhibitors. What are examples of these our monoamine oxidase inhibitors? Remember, antidepressants are used for depressive disorders, and with your monoamine oxidase inhibitors, they interfere with monoamine oxidase, allowing for increased concentration of other neurotransmitters like your epinephrine, your norepinephrine, even our serotonin. And that's going to help to cause stabilization of the patient's mood. So that's what your MAOIs does. And examples of your MAOIs would be our Phenelzine, with the brand name of Nadil. There's also your tranylcypromine with the brand name of Panet. And we also have our isocarboxazid or Maplan. So again, you want to remember them, your Phenelzine, your tranylcypromine, and our isocarboxazid. These are examples of our monoamine oxidase. So if your client is on an MAOI, you need to remember that tyramine-rich foods may cause severe hypertension in this client. So if your client is taking an MAOI, you need to teach them to avoid tyramine-rich foods and even beer. So for example, tyramine-rich food would include your aged cheese, chicken liver, avocados, bananas, meat tenderizers, your salami, bologna, Chianti wine, and even beer, because interaction of your monoamine oxidase inhibitors with this tyramine-rich food can cause severe hypertension in your patients. So you want to remember that for the NCLEX. Again, we want to avoid concurrent use of MAOIs with your SSRIs, because if you use both of them concurrently, you may precipitate life-threatening adverse reactions like your serotonin syndrome. So with serotonin syndrome, if you mix your MAOIs with your SSRIs, it can cause the patient's heart rate to become very fast, very rapid. So you're going to see a blood pressure increase. You see a high blood pressure. There will be muscle rigidity, and there would also be confusion in your patient. So again, if your patient is on an MAOI, like your Phenelzine, and then you place them on an SSRI, we would also look at SSRIs. SSRIs would include your fluoxetine, your paroxetine, citalopram, escitalopram, even sertraline. So if you have them using MAOIs and SSRIs concurrently, it could lead to serotonin syndrome. You could also see neuroleptic malignant syndrome in these patients, like they have this muscle stiffness and then high fever. That's what you will see in these patients. You could also see hypertensive crisis whenever they use MAOIs and SSRIs concurrently. Again, if we're going to use both, we want to have at least a space of 2 weeks. So MAOIs and SSRIs should not be given within 2 weeks of each other, still to prevent those adverse effects we talked about. So please, you want to remember that your MAOIs and your SSRIs should not be given within 2 weeks of each other. Other adverse effects you will see with our MAOIs would include sensitivity to light and also orthostatic hypotension. So again, remember we said you would see orthostatic hypotension and photosensitivity in these clients as part of the adverse effects when they're on an MAOI. Again, if our client is going to be scheduled for surgery, we need to discontinue use of an MAOI at least 10 days before we're going to go for that surgery if we're going to use general anesthesia. So you want to discontinue 10 days before general anesthesia. Okay, so just to remind us, with our MAO inhibitors, your Nadil, your Panet, and Maplan, so NPM is a way of remembering no popular medications. So we don't want to give them barbiturates. We don't want to give them tricyclic antidepressants like our amitriptyline. We don't want to give them antihistamines or CNS depressants or antihypertensives or over-the-counter cold medications. You know, those ones that contain ephedrine. So again, you want to remember no popular meds. So again, you want to tell the client to avoid foods that are rich in tyramine because it can cause their heart to start beating very fast. You want to tell them to avoid old wine, foods that contain tyramine, no cheese, no wine, no pickled foods, because it can cause their blood pressure to increase and cause them to have tremors, dizziness, and sweating. So this is just one way to remind us of what we just covered. With our SSRIs, these are also antidepressants, and these ones inhibit the neuronal uptake of serotonin. So again, they act as stimulants, counteracting depression and increasing your client's motivation. So what are examples of our SSRIs? Your fluoxetine, paroxetine, sertraline, citalopram, and escitalopram. So these are examples of our SSRIs. Remember, we already mentioned it earlier that we don't want to use MAOIs and SSRIs concurrently because of that risk of serotonin syndrome in your clients. So you want to make sure we don't use both concurrently. We also said we don't want to give both of them within 2 weeks of each other. So you want to make sure that if we're going to use both of them, they should not be given within 2 weeks of each other to prevent those adverse effects. Again, for the NCLEX, you need to remember that antidepressants can cause suicidal ideation and behaviors, especially during the initial few weeks of therapy. So in that initial few weeks that we just commenced antidepressants, you need to watch out for suicidal ideation and suicidal behavior in your patient. For example, they start telling you, don't worry, by tomorrow, everything will be fine, but they start giving away their prized possession. You want to start suspecting if it's because of that antidepressants that they were commenced on. So again, with antidepressants, like our SSRIs, we want to give them in the morning. And you want to remember that it takes 4 weeks for them to start getting full effects. We also need to monitor our client on SSRIs for thrombocytopenia, for leukemia, leukopenia, and even anemia. So we want to do a CBC and want to watch out for thrombocytopenia, leukopenia, and anemia in these clients. Again, duloxetine is not an SSRI, it's actually an SNRI, which is a serotonin norepinephrine reuptake inhibitor. So most times it could be used as a pain relieving agent. It can also be used as an antidepressant. The last class of antidepressants we'll talk about will be our tricyclics antidepressants. And examples will be your amitriptyline and our imipramine. Some of the common side effects with your tricyclics would be it could cause sedation in your clients. It could also cause blurred vision, those kind of cholinergic effects like the dry mouth, constipation, urinary retention. We could also see postural hypotension in these clients who could also see adverse effects like palpitation. Remember, like we said, with the antidepressants, there's a high risk for suicide in the initial period that we commenced therapy, usually after the first 10 to 14 days because of that increased energy. So the suicide risk is high after 10 to 14 days because of increased energy in these clients. Okay, we want to also teach them to use sunblocks. And again, there's going to be a delay of 2 to 6 weeks before they start getting any noticeable effects when they are using these tricyclic antidepressants. Let's quickly rush through some NCLEX style questions just to recap all of what we've done. A nurse is caring for a client with a diagnosis of fibromyalgia. So this would be like a condition where you have widespread muscle pain and tenderness. Okay, so during care, the client reports having suicidal thoughts. What currently prescribed medication should the nurse question in regard to this new finding? Okay, so again, we have our selecosib. So which class of medication would your selecosib be? That would be a non-steroidal anti-inflammatory. Again, this doesn't have any effect with suicidal thoughts. We have also cyclobenzaprine. This would be more of a muscle relaxant. And we also have hydrocodone. Again, with your hydrocodone, that would also be another, or it would be a narcotic analgesic. So again, this would not have any relationship with the suicidal thoughts our patient is having. So again, we mentioned earlier that antidepressants cause suicidal ideation and behavior, especially during the initial few weeks of therapy. And the risk is even higher for young adults between 18 to 14 years. And the only antidepressant we have on that list would be our tricyclic antidepressant, and that would be your amitriptyline. A client with fibromyalgia again refuses to take the prescribed drug duloxetine. When the nurse asks why, the client responds, because I'm not depressed. What is the nurse's most appropriate response? Well, we already talked about our duloxetine being a serotonin non-epinephrine reuptake inhibitor. And we said it has both antidepressant and pain relieving effects. So number 2 would be our correct answer, because it can relieve your chronic pain and help you sleep better at night. Okay, so because of time, we might not be going through all of the options. Okay, so now the client is reviewing discharge instructions. The nurse is reviewing discharge instruction with a client going home on linezolid therapy for a vancomycin-resistant enterococcus infection. Which client statement requires further teaching? Okay, so now the client says, I can restart my paroxetine once I get home. So remember we said paroxetine would be an SSRI, and with your linezolid therapy, linezolid is an antibiotic, but it has this monoamine oxidase inhibitor type property. So if our client is going to be on this drug that has this monoamine oxidase inhibitor properties, and is going to use it concurrently with our SSRI, is at a very high risk of coming down with serotonin syndrome. Remember, we said with serotonin syndrome, the heart rate is going to be rapid, there's going to be high blood pressure, you would see muscle rigidity, and even confusion. So again, without even going down the line, number 1 would be our correct answer. The nurse completes the following drug administrations, which would require an incident report. Number 1, client with chronic stable angina and blood pressure of 84/52, isosabide mononitrate held. Okay, so your isosabide has actions that are identical to nitroglycerin, and it can cause hypotension from vasodilation. So it should be held, especially when the systolic blood pressure is less than 90. So that would not require an incident report. How about number 2? Client with depression stopped Phenelzine yesterday, escitalopram given today. Remember, we said there must be a minimum of 2 weeks or 14 days between the administration of an MAOI and an SSRI to avoid serotonin syndrome. These medications cannot be administered concurrently, so we'll need to write an incident report as regards that. Well, like I mentioned, okay, so let's just go through the number 3. Client with diabetes and morning glucose of 90 milligram per DL, the daily MPH insulin 20 units given at 8 a.m. So again, insulin is given to control diabetes, and a normal fasting glucose level of 70 to 99 indicates that the dosing is correct and should be given to continue the control of blood glucose. So this would not require an incident report. Client with pulmonary embolism and an INR of 2.5. So remember, if your client is on warfarin, if he's warfarinized, you want his INR to be between 2 and 3. So 2.5 looks good. It's within the therapeutic range. So again, we won't have to write an incident report on this. So like we said, option 2 would be our correct answer. Let's look at lithium, a mood stabilizer. So it's used to treat mood disorders like your bipolar disorder. You know, with bipolar disorder, you see the client's mood changing between feeling very high, which we refer to as mania, and very low. So it becomes depressed. You also want to remember, when we give this lithium, usually the dosage will be halved during depressive stages of the illness. Lithium also helps to reduce suicidal thinking. Usually, therapeutic effects are preceded by a lag of 1 to 2 weeks. So you want to remember that. And with lithium, the normal blood target level should be 1 to 1.5 milliequivalent per liter. So again, blood levels must be monitored frequently to prevent lithium toxicity or lithium overdose in your clients. So we need to maintain those normal blood level targets of 1 to 1.5. So you want to check serum levels 2 to 3 times weekly when the medication is just started, and then want to check it monthly while they're under maintenance therapy. And the serum level should be drawn in the morning prior to the dose for the day. So again, we talked about lithium toxicity. What are those signs of lithium toxicity that you would see? So you will see those GI symptoms like nausea, vomiting, diarrhea. So those would be like early signs of lithium toxicity. You would also see drowsiness, muscular weakness, ataxia, confusion, and even tremor. So again, with the tremors, you want to remember that fine hand tremors are unexpected side effects of lithium therapy. But if the hand tremors start to become coarse, then that tells you your client is having lithium toxicity. Again, we need to prevent dehydration in our clients that are taking lithium. So you want them to have at least a fluid intake of between 2,500 to 3,000 mils per day, and they need to take adequate salt intake. Remember, lithium increases urine output. It increases thirst in your patient. It increases dehydration because lithium, once the person is urinating, that increased urinary output is going to cause lithium to accumulate in the body. And that's what's going to lead to that lithium toxicity. That's why it's very important that you have them take at least a fluid intake of 2,500 to 3,000 mils per day. Again, with your clients, you want to teach them that NSAIDs increase blood levels of lithium, and that could also cause lithium toxicity. So your NSAIDs, like your ibuprofen, may significantly increase the blood levels of lithium and cause lithium intoxication. Okay, so that's what we need to know for lithium. Let's look at the test question on lithium. The nurse is reinforcing discharge instructions for a client who is prescribed lithium for management of bipolar disorder. Which of the following instructions are appropriate? Select all that apply. Number 1 says drink at least 8 cups of fluid throughout the day. Okay, we already said we want to prevent dehydration in our client because lithium causes increased urinary output. And again, with that excess loss of fluid, is going to cause lithium to be retained in the body and could lead to lithium toxicity. So we want to prevent dehydration in our clients. So option 1, we'll go with that. How about option 2? Eat a low sodium diet as recommended. Again, with lithium, sodium and lithium have like an identical ionic charge. So when serum sodium levels are low, the kidneys reabsorb both sodium and lithium, all in a bid to reestablish electrolyte balance. So this can now precipitate life-threatening lithium toxicity because the body keeps reabsorbing lithium, kind of mistaking it for sodium. So again, we won't want them to eat a low sodium diet as recommended. So I'm going to take this off. Expect routine blood tests while starting this medication. Yes, we said we'll have them carry out frequent blood tests in the immediate period and then 2 to 3 times a week and then once monthly. So we'll go with option 3. Report diarrhea to the healthcare provider. Again, we said you would see those early manifestations of lithium toxicity as those GIT symptoms. So again, once the lithium levels are above 1.5 milliequivalent per liter, you will start seeing those GIT side effects such as persistent nausea, vomiting, and even diarrhea. So we're going to select option 4. And option 5, take ibuprofen as needed for mild pain relief. Again, we said those NSAIDs can increase blood levels of lithium, causing lithium toxicity. So we're going to eliminate this option. Okay, so that's just a picture to guide us. So when the lithium levels are over 1.5 milliequivalent per liter, the client could become toxic. It could have lithium toxicity. So the I, so you're spelling lithium here, the L levels over 1.5 I, you want to increase fluid and also sodium. Remember we said the body confuses lithium with sodium because there's a high risk of toxicity. So avoid dehydration and anything that will affect your sodium levels. So you want to avoid hyponatremia. Remember, your normal sodium levels would be 135 to 145, so you won't want it going below 135. Don't limit sodium or water intake. Okay, with T, we're looking at toxic signs to report: your excessive urination, extreme thirst, vomiting, and diarrhea. And H would mean to hold NSAIDs like your ibuprofen and your naproxen. Remember, NSAIDs decrease renal blood flow, which could also result to a high toxicity risks. And the last medication we'll review for today would be our benzodiazepine. So we could have them as benzodiazepine derivatives. And examples of your anti-anxiety medications that are benzodiazepine derivatives would be our chlordiazepoxide, also known as Librium, our diazepam, our apraxolam, our lorazepam, or it's also called Xanax, oxazepam, and our midazolam. So again, with midazolam, it's usually used for preoperative sedation, even conscious sedation for endoscopic procedures and diagnostic tests. So most of these anti-anxiety medications have the CNS depressant effect. Your benzodiazepine derivatives has this potential for addiction. You want to remember flumazenil is the antidote for a benzodiazepine overdose. So again, these benzodiazepine anti-anxiety medications have a very high potential for addiction. And part of the adverse effects would include respiratory depression, orthostatic hypotension, and even confusion in your clients. You also want to remember not to stop. Well, generally for all medications, we don't want to stop them abruptly because it could precipitate withdrawal symptoms, especially with your benzodiazepine. So let's look at anxiety medications that are non-benzodiazepine derivatives. Examples would be your buspirone and our hydroxyzine. And they are particularly useful for generalized anxiety disorders. Again, these non-benzodiazepine derivatives have little sedation effect. They don't have any CNS depressant effects. We also want to monitor clients that are on these medications for worsening depression or suicidal tendencies. These non-benzodiazepine medications do not produce withdrawal symptoms. They have low dependence or they don't produce psychomotor slowing. So you don't see those slowing of thoughts or impaired movements in clients on this medication. And maybe their driving would not be affected. So that would be one benefit of your non-benzodiazepine. Again, it requires approximately 3 weeks to be effective. So onset of symptom relief occurs after 1 week of therapy, with full effects occurring between 2 to 4 weeks. So approximately 3 weeks to be effective. And we're going to close with some test question. The nurse has provided education for a client newly prescribed alprazolam for generalized anxiety disorder. Which client statement indicates that teaching has been effective? Again, we said benzodiazepine have a sedative effect and they should be administered at bedtime when possible. Benzodiazepine should never be stopped appropriately. Already talked about that because it could precipitate withdrawal symptoms. So again, which client statement indicates that teaching has been effective? Option 1, eliminating aged cheeses and processed meat from my diet is essential. Does that show that teaching has been effective? So again, when we talked about aged cheese, I remember we talked about foods containing tyramine and processed meat, and these measures will only be effective for clients who are on a monoamine oxidase inhibitors like your Phenelzine, your tranylcypromine, and they are used for depressive disorders. So it's not necessary to avoid or eliminate aged cheese or processed meat. How about option 2? I can skip doses on days that I'm not feeling anxious. Again, a benzodiazepine should never be stopped abruptly. We talked about that. Instead, you want to taper it gradually to prevent rebound anxiety and that withdrawal reaction that will be characterized by increased anxiety and confusion. So again, we don't want to stop our benzodiazepine abruptly. So I'm going to also eliminate this. I will take my daily dose at bedtime. Okay, so we said benzodiazepines like your alprazolam, which is your Xanax, your lorazepam, which is your Ativan, our clonazepam, diazepam. These are your benzodiazepine. They are commonly used for anti-anxiety problems, for anxiety problems, sorry. Again, it may cause sedation, which can interfere with your daytime activities. So giving the dose at bedtime would also help the patient to sleep well. So this shows teaching has been effective. And how about 4? Using sunscreen is important as this drug will make me sensitive to sunlight. Again, photosensitivity is a problem with most antipsychotics and many antidepressants, but not with your benzodiazepine. So I'm going to also eliminate this. Option 3 would be our correct answer. Okay, the nurse reinforces teaching for a client newly prescribed pospirone for generalized anxiety disorder. Which client statement indicates that teaching has been effective? Okay, so again, pospirone is an anxiolytic medication, and we said it doesn't have this central nervous system depressant effect. It doesn't cause dependence, it doesn't cause tolerance, it doesn't cause psychomotor slowing or those withdrawal symptoms. We also said full therapeutic effects occur between 2 and 4 weeks of therapy. Okay, so let's review all of the client statements. We're looking for the statement that indicates that teaching has been effective. So again, the client says driving is not recommended until I stop taking this medication. Well, this is the first dose, a newly prescribed. So newly prescribed there tells me the client just started taking this medication, but it's unlikely that pospirone would cause psychomotor impairment and would require stopping driving. So again, this does not show that teaching has been effective. I'm going to eliminate it. Remember, we said pospirone will not cause psychomotor impairment and it doesn't require the patient stopping their driving activity. How about number 2? If I experience a panic attack, I should take an extra dose of medication. Well, generally, you want to stick to your prescription. So your pospirone should be taken as prescribed. And normally don't use it for relief of acute anxiety or panic attack. So again, the healthcare provider might need to prescribe an additional medication with a fast-acting effect if the client is experiencing panic attacks. So again, this doesn't show that teaching has been effective. It will be 2 to 4 weeks before I feel the full effects of this medication. Okay, that sounds more like it. Remember, we said pospirone is an anxiolytic medication and it's used to manage anxiety disorders. We said it lacks those central nervous system depressant effects and it has a low abuse potential. But it doesn't work like other medications that work very fast. We said the onset of symptom relief occurs after 1 week of therapy and the full effects could be seen between 2 and 4 weeks. So again, option 3 would be my best bet, but let's still review option 4. Withdrawal symptoms will occur if I abruptly stop this medication. Again, pospirone does not cause physical dependence or tolerance or withdrawal symptoms do not occur if they stop these medications abruptly. So we're going to eliminate option 4. Option 3 would be our best answer. I think let's look at antacid medication, which is just one slide. Again, it's used to treat temporary discomforts of the stomach and gastrointestinal tract, such as your nausea, heartburn, indigestion, upset stomach, even diarrhea. And one example would be your bismuth subsalicylate. But again, I just want you to take note of the salicylate in our bismuth subsalicylate, which is aspirin. So again, bismuth subsalicylate contains aspirin, and it could possibly cause Reyes syndrome in your patient. So Reyes syndromes, what do you see? You see acute encephalopathy. You also see hepatic dysfunction. So those are the two common signs you will see with Reyes syndrome. So remember, it can develop in children with a recent viral illness, such as varicella or your chickenpox, or if they have influenza. It's also called the flu. So again, if a child has a recent viral illness, such as varicella or chickenpox, or maybe the flu, the child can develop Reyes syndrome. So you don't want to give children with viral infections aspirin or any product containing salicylates. So again, you have this test question. A parent calls the after-hours triage nurse about a 3-year-old who is sick with the flu. Which report by the parent would necessitate intervention by the nurse? Number 1 says acetaminophen being given every 4 hours for the fever. Well, that's good. If we do this, we can give acetaminophen for the fever. She says bismuth subsalicylate being used for nausea. Again, that's our salicylate there. Remember, the child has a flu. So again, we said we don't want to give aspirin to children who have a flu or who have chickenpox, because it could lead to Reyes syndrome, where you're going to see encephalopathy or brain dysfunction, and you'd also see liver damage in these clients, okay? So option 2, we'll hold on to that. With option 3, ibuprofen given for body aches, that looks okay. We can also give popsicles and gelatin to hydrate the patient. So option 2 is our correct answer. So again, like we said, Reyes syndrome for children with flu or chickenpox, we don't want to give them aspirin because it could cause Reyes syndrome. And you're going to see encephalopathy, and you'd also see liver damage. Okay, so we'll continue on the next date with our anticoagulants. I will put up a recorded version of this video so that we can review it